evening, everyone. My name is Howard Davies from Sheffield. I'm pleased to welcome you to the 8th lecture in the BOFAS Registrar webinar series. Tonight we've got a talk on list rank injuries by Robert Clayton, who is a consultant foot and ankle surgeon from Fife and is also pivotal in organising the lectures as part of the IT committee, and also has the distinction of having played fly half for Scotland in the 1995 Six Nations series, so quite a talented guy. So over to you, Robert, and then after the lecture we'll have some questions from everyone. So if you do have any burning questions, please add them and we'll try and get through as many as we can later. Thank you, Robert.
Good evening. Can you hear me okay, Howard? Good. So yes, welcome to the next lecture of distinction in the BOFAS webinar series. I'm going to talk about list rank injuries. Welcome all questions. Please do keep them coming on the Q&A section, and I'll take as many of them as I can at the end of the lecture. So, list rank injuries. A few things that we'll aim to cover. And we'll end with controversies, because that's always good. So who was Mr. Lisfranc? Jacques Lisfranc de Saint-Martin, Napoleon's field surgeon. He had an illustrious history. Remember, he was in the pre-X-ray era, so he had to diagnose fractures with a stethoscope, and I don't think we'd really fancy that in today's COVID times. He didn't describe a Lisfranc fracture, but he did describe a quick, bloodless midfoot amputation. But on to more contemporary times. Now, this is the extreme end of the spectrum of a Lisfranc injury, a man who was crushed by a steamroller. We do see a number of high-energy Lisfranc injuries, but we'll also see a lot of low-energy Lisfranc injuries, which are a lot more subtle than this and require a rather more subtle approach. They're common. 0.2% of all orthopaedic injuries maybe doesn't sound like a lot, but they are common and they are often missed. Delayed presentation being an unfortunate euphemism for that. So they are difficult to treat. The anatomy is complex, but I hope to try and demystify that a bit for everyone. But the ones that are missed will unfortunately quite often end up in this litigation, and I will try and help everyone navigate a way of avoiding that. So the anatomy. There is only really one thing I want you all to remember from the rather complicated slides. The key thing is this ligament, the Lisfranc ligament, which runs between the medial cuneiform and the base of the second metatarsal. And that is really integral in holding together the Lisfranc joint. The Lisfranc joint is the row of tarsal and metatarsal joints. Call it the Lisfranc joint or the Lisfranc complex. This ligament, the Lisfranc ligament, is absolutely integral to all of this. The intermetatarsal ligaments then hold the metatarsal bases aligned against one another. And in the low energy injuries, most commonly it is simply the Lisfranc ligament, either ligament rupture or avulsion fracture that's injured, and all these are intact. So once you've restored the anatomy of the second tarsal metatarsal joint, you've fixed the problem in the low energy ones. And in the high energy ones, all bets are off because all manner of things can happen. So there it is on cadaveric section and on more advanced imaging. There it is in all its glory. There's the medial cuneiform, there's the base of the first metatarsal, middle cuneiform, second metatarsal, and there is the ligament. And so it's fairly easily visualized on MRI. Now it's always talked about, you'll have heard this term, it's referred to as the keystone. And what that means is the Romans got there, they designed arches, and the keystone is the one at the top, such that when you stand on it, even if these aren't actually joined together, the force is imparted equally down either side and the whole thing stays up without any additional reinforcement. Now, of course, in every modern day arch or in the bones of the foot, you've got other structures, namely the ligaments, holding everything together. But the idea is that you can put an axial load downwards from the top of the middle cuneiform or the second metatarsal base, and the whole thing stays up under the sort of tapered structure of the anatomy of all these bones. The columns are important to remember, and really this is critical with all midfoot fractures, Lisfranc injuries, but also the sort of more esoteric fractures around the navicular, the cuboid, and the cuneiforms. Think of the columns. When you're fixing these fractures, one of the key concepts in the high energy Lisfranc's or the other midfoot injuries is to restore the length of the medial and lateral column. So the medial lateral column is simply everything here. So the navicular, the medial cuneiform, and the first metatarsal, and the lateral column, simply the cuboid and the fourth and fifth metatarsals. And if you can restore that anatomical alignment, bring those columns out to the correct length, then you're winning most of the battle on restoring what might otherwise be very odd-looking, complex midfoot injuries. And in the low-energy Lisfranc's, and in pretty much all the high-energy Lisfranc's, it's the middle column that's the most critical one, the middle and lateral cuneiforms and the second and third metatarsals. So the anatomy is complex, but just remember, if you don't remember anything else about the anatomy from this lecture, remember what the Lisfranc ligament is, from the medial cuneiform to the base of the second metatarsal. So I've shown you the slide of the one who was run over by a steamroller, and high energy injury. Low energy injury, I've seen it when people have fallen off a table at a wedding. Remember those days when we actually used to be allowed to gather together? And I live not far off this place, Knock Hill Racing Track, which does bring me a fair share of high energy trauma to my practice as well. The high energy ones would predominantly be from RTAs of some form or another. And in the high energy injury, like anything else in the foot, look for the other injuries first. But the low energy ones are subtle, and I'll give you some tips as to how to pick them up. The low energy ones, classically a crush injury, but also axial loading, so open fractures, that's pretty rare. You can get this direct force where you can imagine a sort of shear force here, where a dorsal force on the base of the metatarsals would push these metatarsal joints out of line. But very commonly an indirect force, and classically it's an axial load of a plantar flexed foot, hence the person falling off the table at a wedding, landing on the toes. Plantar flexed foot leads to this axial load, which leads to disruption of the Lisfranc ligament and subluxation of the tarsometatarsal joints. And then any other sort of twisting injury or anything else, direct injury, indirect injury to the midfoot that you might care to name. So direct forces, indirect forces, in many ways, the mechanism of injury can sometimes be overplayed. The key is to recognize it and treat it. So a lot are missed. Now, I don't know how clearly this slide shows, but this is a typical sign. Bruising on the sole of the foot, plantar ecchymosis. If you've got a bruise on the plantar aspect of the tarsometatarsal joint area, that really is a Lisfranc injury until proven otherwise, and you've got to try pretty hard to disprove it because it's almost certainly that. That's a great sign if you see it, or if your casualty person sees it and refers it on to you, but you don't always. But just beware of the ones with subtle swelling on the midfoot. And in today's era of virtual fracture clinics, you may be doing virtual fracture clinics where you see what looks like a normal x-ray of a foot, but you can see a soft tissue swelling, or you read the casualty sheet and it says the patient had bruising and swelling over the midfoot. Bring those patients back. Do not ignore them, because there's highly likely to be a Lisfranc injury. And just to labor the point, 40% are missed, and that's bad news. So I like to get an AP in a lateral and oblique x-ray. In my fracture clinic, I can do that, but for some reason, my own casualty department can't get lateral images, and I suspect that's probably the case for a lot of you. So you will usually be presented in the fracture clinic first up with an AP and an oblique x-ray and no lateral, but you can gain an awful lot from those images. And the key thing is to line everything up. So here on the medial border of the first ray, sorry, the lateral border of the first ray, everything lines up nicely. But you can see on the medial border of the second ray, there is a little step there between the medial border of the middle cuneiform and the medial border of the second metatarsal. And look at the oblique view here on the same foot. On the oblique view, you can look at the third, the 2-3 and the 3-4 intervals, and those line up nicely there. And of course, sometimes you get a lateral x-ray, and sometimes you can see a very obvious abnormality, but it isn't always as obvious as that. So again, here we are. Look at where everything lines up. the 1-2 interval, the 2-3 interval, the 3-4 interval. And I'm not sure that measuring 3 millimeters at the base of the fifth is particularly helpful to you. This is an important sign, coming back again to that Lisfranc ligament from the middle cuneiform to the base of the second metatarsal. It's often an avulsion fracture. You see this Fleck sign. That bit of bone has avulsed from there. So that the Lisfranc ligament itself is intact, but it has avulsed its insertion on the base of the second metatarsal. And there's widening of the 1-2 interval. Not very greatly widened. It's subtle. If you aren't actively looking for it, you will miss it. Don't forget the cuboid. There's some disruption around the cuboid, and the fourth and fifth tarsometatarsals don't look normal, but again, it's very obvious that there's something bad going on at the second TMT joint. Now, imaging, standing views. So when they come back to you in the fracture clinic and you suspect a Lisfranc injury, if the patient can bear weight on it, a weight-bearing X-ray will give you a lot of useful information. And you'll get a weight-bearing true lateral and a weight-bearing AP, and they may give you the answer that you're looking for. I put query opposite side for comparison. A lot of radiology departments won't allow you to X-ray a contralateral normal foot. Screening under anesthetic, well, by then you've sort of upped the ante, haven't you, in terms of your diagnostic pathway. Advanced imaging, a plain CT scan is essential, and I suspect more and more in the future we will see standing CT scans being used. I know some people have access to that. At the moment, it's relatively uncommon, but I think that will transform the diagnostic pickup rate for these injuries once it rolls out. Stress testing, again, there you are, you suspect it, you manipulate under anesthetic, and if you just put an abduction strain on, or an adduction strain on the forefoot, you can see it opening up for you at the 1-2 interval, and you make your diagnosis and you fix it. Sometimes there's no fracture. It may be a purely ligamentous injury with subluxation or overt dislocation of the tarsometatarsal joints, and that's what we're seeing in this one. But scan everything. If in doubt, scan it. If you found a definite Lisfranc injury, scan it. You'll get a huge amount of information that helps you plan your operation. Scan and plan. And again, sometimes you already knew this was a Lisfranc injury before you put the patient through the CT scanner. But as you roll through the sagittal images, particularly the sagittal cuts on a CT are very valuable. You can see, you know there's something at the second, but you can see whether there's something at the base of the first or the third that you might have missed or might not have been so easily apparent on your plain X-rays. MRI, I don't use all that often, but it can be valuable. Again, if you suspect an isolated ligamentous injury and everything looks congruent and lined up, you might get an MRI scan to look at the soft tissues and to look again at the Lisfranc ligament. Now, people love to classify everything. I'm not sure that with Lisfranc injuries, it's particularly helpful to classify things. Classification systems are useful if they tell you what to do, but they're not prognostic. They probably don't tell you how to fix it. They just make you think about it a bit. But they can be classified by the columns, the medial column, the lateral columns, the middle column. And again, if you see the different columns involved, you know that those all need stabilizing at your definitive surgery. And I'll skip past this. This is the classification I find useful. They're displaced or undisplaced. If they're displaced, you're going to fix them. If they're undisplaced, you can argue for not fixing them. You need to watch them very closely if they're undisplaced, and you can then debate whether to weight bear them early in the hope that it displaces quickly so you can fix it, or completely non-weight bear them in the hope that it doesn't displace at all. And I'm not sure what the right answer to that is. But displaced or undisplaced, you really want to know whether or not you need to fix them. If they're displaced, I put it to you that you should. So is it stable or unstable? Is it ligamentous, bony, or both? And what have you seen? What are the soft tissues like? In the low energy ones, that's not likely to be an issue, but in the high energy ones, that is going to really dictate your operative strategy as much as anything else. When to fix them and by whom? These are complex injuries. They're pretty straightforward in the hands of people who do them all the time, but they can be complex, and the difficult ones are difficult no matter who's doing them and when. They can wait most of the time. There'll be occasions where there are soft tissue issues where if you're the generalist on call, you need to do something quickly. But most of the time, the definitive fixation can wait safely to be done by your foot and ankle specialist, rather than needing to be done in the middle of the night or on a Saturday when someone less familiar with them is having to go outside their comfort zone. But you need to reduce it anatomically. That is the key goal. Everything else is secondary to that, because once you've reduced it anatomically, all of these things will happen anyway. And as I'll show in a slide coming, the outcomes really are proportionate to the accuracy of the surgical reduction that you achieve. Anatomic reduction. We can discuss what whizzy metalwork you put in to hold your anatomic reduction, but if you haven't reduced it anatomically in the first place, then you haven't done the patient a favor. So here we are. This is a score for the accuracy of the reduction. We don't need to worry too much about the detail of how that's calculated, but the ones with a really good, accurate anatomical reduction will do well in the long run. But if you reduce them poorly, if you don't reduce them properly, they will get a poor outcome. And there is a very clear inverse correlation between the accuracy of your reduction and the long-term outcome for your patient. So poor prognostic indicators. Well, the crush injuries, where there's a lot of fracture and there's a lot of soft tissue injury. I suppose it's common sense they're not going to do as well. A lot of comminution. Pure ligamentous injury, or really very badly damaged intra-articular injuries. Those two groups will also have poorer outcomes. Now, again, when do we operate on them? If everything's bruised and very swollen like this, you may well want to leave them a week or two, even 2 weeks, before you can come back and properly address them to avoid compromising the soft tissues. In ones like the previous slide, where there's multiple fractures and multiple joints involved, you know you're going to need to make 2 incisions. And if the foot looks like this, making your 2 incisions is going to be hazardous until the swellings come down. And you're probably going to be best off leaving that until the swelling has improved so that your soft tissues are safe, and wait till it's started to wrinkle up a bit and you know you're less likely to compromise the soft tissues. I'm not going to talk about compartment syndrome. Anyone who was listening last week will have had an excellent talk by Errol Ramasamy about that and all the controversies therein. Medial and central column plates, lateral column K-wires. That's the classical sort of textbook description of how you fix Lisfranc injuries. I put it to you that most of the time you don't need to do all of that, but have in mind that you would be fixing the first, second, and third rays with some form of plate if you're going to fix them, and you might try and stabilize the 4th and 5th with K-wires, because the 4th and 5th tarsometatarsal joints are very mobile, whereas the 1st, 2nd, and 3rd don't move very much, and it doesn't matter so much, particularly the 2nd and 3rd, if you fix them more rigidly. In an isolated ligamentous injury, there is evidence to suggest that primarily fusing them is a better option than fixing them and having to go back. If they're undisplaced, you cast them or you put them in a moon boot, and you probably non-weight bear them, but you certainly keep a close eye on them, whatever you decide to do, to ensure that they don't go on undisplaced. And I'll talk now about the key different fixation strategies. I'm not going to talk about frames. The tightrope is talked about, but again, I'm not going to go into that in any detail. Primary fusion. This paper is one of the sort of cardinal papers in Lisfranc injuries, a randomized trial by Chris Kurtzier from America, comparing the purely ligamentous injury, so there's no fracture, but there's a dislocation or subluxation of the tarsometatarsal joint, and comparing surgical arthrodesis of the affected joints with transarticular screws, and he found that the arthrodesis group did better. I put it to you that transarticular screws are not a good thing to do in the first place, because I don't think there's really anywhere else in the body that we routinely try to achieve skeletal stabilization by putting a screw across a joint. So this again is described in the textbooks. And here's a bridge plating where there is a screw mimicking the Lisfranc ligament, so going from the base of the second metatarsal into the medial cuneiform, which is really the keystone of all fracture fixation here, and a bridge plate with no screws actually across the joint. And that's an excellent way of stabilizing things. And we'll talk about whether you leave those plates in or take them out. But I really don't advocate this, screws across the joint. Some people still do, but I think that really does predispose to long-term pain. And I think that's why these injuries get a much worse name than perhaps they deserve. So here you are, you might see this injury in your fracture clinic. Now, I'm not a shoulder specialist, so far be it for me to tell you how to deal with it, but I'd be pretty sure you wouldn't advocate fixing it by putting a screw from the humeral head into the glenoid. And similarly, I don't advocate that you put screws from the metatarsal into the cuneiforms across the joint. Bridge plating is, in my view, the best way of getting a good result for these injuries, particularly the low energy ones. You can put a screw along the line of the Lisfranc ligament. This is not a transarticular screw because there's no articular cartilage in that very narrow interval there. So if you can get your screw from the medial cuneiform into the base of the second metatarsal, along the line of the Lisfranc ligament, you can then put an extra articular bridging plate across the tarsal-metatarsal joint and get excellent reduction and get good stability. And I find a 1/4 tubular plate has enough flexibility for you to be able to contour it easily, and for it also to have a little bit of give in it if you've got multiple ones to fix, or even just for normal movement once you do start to allow them to bear weight. In this one, I've put the screw in that way. Now, I would now put them in the other way, retrograde, because that goes in through a very small hole if you put it in from the medial cuneiform, but it requires a much bigger hole to find the head of the screw to take it out again if you have to go back. Whereas if you put the screw in from the second metatarsal base into the medial cuneiform, then if you do have to go back, you've got to reopen this incision to take the plate out anyway, and it's no harder to find the head of the screw. Technically easier operation at your next stage if you do have to revisit it for any reason. But this is the sort of thing you can do. So this is a low energy, relatively subtle Lisfranc injury, but you can get an excellent reduction. And here's one with injury to the base of the second and the third. And the principles are very much the same. For this one, I've fixed the third, and then I've examined it under anesthesia and found that the second has just followed the third into an excellent reduction, and I haven't needed to put any extra fixation on the second. So you can be much more selective about the number of rays you're fixing. I'm going to non-weight bear this patient anyway for the first 6 weeks. And if I've got an excellent reduction that's being held by my plate fixation for one ray, I will not feel it necessary to add a whole lot more medical work in to fix the other ones if the reduction's maintained. But yes, beware the columns. Now this is quite subtle, but here, if you look at the base of the fifth metatarsal, you can see this is impacted into the cuboid here. And if you were to just treat the central columns here, you will ignore that and you will leave that lateral column short, and that will leave the patient with an abduction deformity. And there's that same patient on CT scan, and you can see again the base of the fifth metatarsal impacting into the cuboid. So to fix that, it required opening it up on the lateral side and just gently levering out the impacted parts of the cuboid. And I put a big long bridge plate here across the lateral column to hold the whole lateral column out to length. And that, of course, does oblige me to go back and take that metal plate out later on when the swelling's coming down, because otherwise that's going to immobilize the calcaneal cuboid joint break and cause problems. Here's an isolated ligamentous injury. And again, we can debate, as I was alluding to from Chris Coates's paper, whether to perform primary fusion or whether to fix those with a transarticular screw. But the other solution is to take them to theatre, reduce it. They tend to reduce down quite nicely closed, and then fix it with bridge plates. So the same screw, this time I have put it from the second base into the medial cuneiform. In this one, I did have to fix the second and the third because they were both unstable. But a simple bridge plate restores the anatomy very nicely. And those patients then tend to do very well. I keep them non-weight bearing for 6 weeks. and then allow them to start weight bearing in a moon boot for over the following 6 weeks. And that's the longer term follow-up. Now here's the other extreme. This is a patient I showed at the outset. This man had been run over by a steamroller, and you can look at that and you can think there's all sorts of odd things going on there, and I'm really not quite sure what's injured and what's not. Scan everything. I'd scanned the previous one. I'd certainly want to scan this, and you kind of get the feeling there might be something going on there at the navicular cuneiform joint, as well as the base of the base of the metatarsals. And sure enough, you scan them and you see there is dislocation there of the navicular cuneiform joint. And coming back to the columns, you've got to clearly reduce that dislocation. You've got to stabilize the medial column and hold it out to length. And that's the critical stage of your reduction. So to do that meant I couldn't reduce it closed, meant opening it up, putting a bridge plate all along the medial column, which again has to come out later on because you've bridged across the tailor-navicular joint and all the way down. And then small bridge plates across the second and third tarsometatarsal joints. And by the time I'd done that, even then the fourth and fifth are sitting very nicely, so I didn't have to expose further laterally to do anything there. And in the very extreme ones where you've got really marked soft tissue injury as well, you may need to put on an external fixator here. This isn't one of mine, but here's some internal fixations being put on the medial side, with an external fixator to jack the lateral column out to length to hold it there to prevent that all shortening up. So do we leave the metalwork in or take it out? You're bridging a joint. So in theory, if you've left these plates in, then you've probably de facto created a form of an arthrodesis. Except you haven't, because what will usually happen is either the screws break or the plates break. The patient never knows about it. These joints don't move very much anyway. I used to routinely take all these out, and it was actually a patient that changed my management. A patient who was doing absolutely fine at the 4 or 5 month mark came back and said, well, do I really need another operation to take the plate out? We can't make you any better than you already are. So no, I now put it to the patients and usually leave them in. It's pretty uncommon if you've situated the metalwork correctly that it causes any problems with prominence. These are relatively low profile and they tend not to be palpable under the skin. Clearly, in this example, where you've bridged across the medial column, the tailor-navicular joint, that's got to come out. So routinely, I will always immobilize them non-weight bearing in either a cast or a moon boot for 6 weeks, and then get them going with physiotherapy. These are all important things. Do watch out. There's not much you can do about CRPS, but the crush injuries, the higher energy ones, the crush injuries really are at high risk of neuropathic pain type problems. When to let them return to sport? Really, it's a phased return, isn't it? It's start off gradually with the less physical, non-load bearing sports, lower impact, swimming, cycling, and build up from there. If you are going to remove the metalwork, I'd wait till the swellings come down, partly because of course it's technically easier to open it up, find the metalwork and to get a good closure. And secondly, because the swelling is a good surrogate marker for when the ligaments have nicely healed up. And when the swelling's down, then you know that things are strong enough to withstand removal of the metalwork. It's a soft tissue injury, particularly the higher energy ones. Do watch out for what you're doing with the soft tissues, where you're making your incisions. Keep in mind to maintain a skin bridge of 5 centimeters. Know the fracture. So really that means scan it. Scan it so you can plan it. Always scan. And get an anatomical reduction and bring the columns out to length. Complications. Well, again, laboring the point, malreduction. All of these other things can happen. Hardware prominence, relatively unusual with the small low profile plates in the midfoot, but clearly more likely to be a problem if you've had to put plates on the medial border or elsewhere. Breakage maybe doesn't matter. And all the other things, neuropathic pain, venous thromboembolism, as we're all familiar with. But arthrosis, this is what we're trying to prevent. If you leave a Lisfranc joint subluxed, then there is a very high rate of arthrosis later on. There's also a high risk of midfoot collapse, and you can end up with a flat foot deformity with you get the true lateral weight-bearing view of someone coming in with a flat foot in years down the line from one of these injuries. And they've got a flat foot with a clear disruption at the tarsometatarsal joints. This is why we're doing this, to try and prevent those two complications further down the line. So infection is rare in the low energy injuries, but clearly a problem in the higher energy injuries. And in these ones where you've got soft tissue complications or bad soft tissues to start with, it may well be a case of liaising with your local plastic surgeons at the outset when you're working out what to do about soft tissue coverage. So here's that, sort of midfoot collapse that you can get if you undertreat these injuries. And why will you injure the cartilage? Well, sometimes the cartilage is irreversibly injured from the time of injury, and there's really not much you can do about that apart from do all you can to restore the anatomy. If the cartilage, if the joint, particularly the second and to an extent the third metatarsal bases, are really heavily comminuted with intra-articular fragmentation, then seriously think about a primary fusion, because you know that there's a very high chance that joint's going to heal and leave pain. And so, yes, a very comminuted articular surface, primary fusion is going to be the best long-term outcome for that patient. And fusions, we've had a talk about midfoot fusions earlier in the series, which if anyone hadn't heard about it, Anna Chapman covered very nicely a few lectures ago, so I won't go into that in any detail either. But again, this is what we're trying to prevent, and good stable fixation will do that. But these are why these injuries get a bad name. You can see the lucency around the screws here as the patient starts to bear weight with a non-fused but rigidly fixed joint. The screw loosens in across the joint. It leaves a mobile track, which is painful and leads to further articular damage. So just really to end now with the controversies, how to fix them. Will you use a screw? Will you use transarticular screws or a bridge plate? I've given you my view on that. Do you need to use locking plates, or will a simple non-locking plate do? Which for most of the simple midfoot ones, a non-locking plate will be fine. Do you remove the fixation? Which way round to put the screw? Where do you place your incisions? Again, there'd be the textbook answer of place one incision over the 1-2 interval and the other incision directly over the third ray. Actually, you can place the incisions within reasonable limits where you think you like, wherever you're going to get best access to the fracture in front of you. So for the low energy ones where it's an isolated second ray problem, I'll make the incision directly over the second ray, which will allow me to unpick everything from the 1-2 interval and get a screw from the lateral side of the base of the second metatarsal. But if I've got more than one ray to address, then I'll locate the incision where I'm going to get best access to the things I need to fix. Get it right first time. Revision surgery, just like any other injury, revision surgery is going to lead to a much poorer outcome than if you got it right and reduced it accurately with your primary surgery. So really, that's all I need to say. And now it's time to take any questions, and over to Howard.
Yeah, thank you, Robert. Thanks for a fantastic talk. It was very clear. So a couple of questions come through from the audience. Firstly, how much displacement can be accepted for non-operative treatment?
Well, good question. I mean, I would say none. If it looks displaced, it's displaced. If it's undisplaced, it's undisplaced. If you can see a millimetre or two of displacement, that's quite a lot in the context of a joint that's not very big. And so if you see that widened interval, again, it depends on your patient, doesn't it? But in most patients, fit active patients, fix it. I'm in agreement, I guess, with the only caveat being that sometimes you do get a Lisfranc fracture in someone with arthritis. And in those guys, if the joint's already fairly well worn or fairly been painful preoperatively, and it looks stable on weight-bearing x-rays, then I might give it a run for its money and just primarily fuse it down the line if things don't settle, I guess. But I'm very much in agreement that there's no room for displacement really in the midfoot. It's a finely engineered bit of kit. It should fit together like a jigsaw, and any displacement at all is likely to lead to trouble down the line. So you have to really, really convince me, or the patient would have to convince me in effect that
it's, you know, they've got this damaged joint anyway, and we don't need to do anything to improve that.
If there was already arthritis and I was going to fix it, then I'd primarily fuse it, because you know that you've stirred the pot with the injury and the surgery, and you're almost certainly going to be back fusing it later if you don't.
Yeah, absolutely. Second question, it says, one, unstable dislocation with bad soft tissues, how to manage? So I guess, how do you manage we showed some fantastic photographs of very, very swollen feet with horrifically comminuted injuries. How do you go about managing those? Do you do anything rather other than put them in a plaster while you wait for things to settle down? Would you put an X-fix on, or do you do anything differently?
Good question, because I suppose they're a very heterogeneous group of injuries, aren't they? And it depends what you are dealing with. I don't want to leave the joint dislocated. It may be that I'm going to, if sometimes the central metatarsal joints will reduce closed even in a very swollen foot, and just a bit of gentle pressure will get them to reduce, and you can then buy a bit of time and wait till the soft tissues improve. I showed that one of the steamroller injury where the navicular cuneiform joint was dislocated, and that wasn't going to reduce closed. So I don't like to leave them dislocated. And if they are very swollen, they're partly swollen because they're dislocated. And then no matter how long you leave them, they're going to remain swollen because there's a dislocated joint there. So in some of those, there's no benefit really in delaying things for any great length of time. But by reverse, other times they're so swollen that you really don't want to do anything. So there isn't an easy answer for those. Some of the times I may have to make a limited incision to reduce something and accept and plan to go back later on and possibly put an external fixator on to hold things if I don't think it's going to stay reduced in a cast. It's difficult to generalize because you really do need to scan and get a feel for what exactly you're dealing with.
Yeah, they are, like you said, very heterogeneous group of injuries. They're very, very difficult to plan and predict. I think if it was extraordinarily unstable, we certainly in our unit have history of putting external fixators on both columns just to try and hold it out to length and protect the soft tissues. But that in itself comes with all kinds of issues, regarding they're still often unstable and you don't always get to reduce the joints. Speaking of which, just a quick question, but sometimes it was one of those unfair exam questions. So if a patient presented as a steamroller patient did with a dislocated cuneiform, would you rush that patient to theatre in the middle of the night, or would you wait till 8 o'clock the following morning if they came in at 10 o'clock at night? What would you advise a general colleague to do who's a shoulder surgeon?
I would suggest leaving it till the next day, unless there were other reasons why you needed to do it in the middle of the night. But I think if that steamroller injury one, most of the time you don't need to do that in the middle of the night. You've got a difficult injury if it's someone who's not familiar with these injuries. Those are difficult injuries for you and me, and for someone not familiar with those injuries, it really is an impossible situation. I would actually prefer them not to do anything so that I've got a clean sheet, as it were. Sometimes someone else, meaning well, will make an incision just exactly where you don't want one, so that they can get a joint reduced, so that they can go get some sleep at night. But then when you come back and do the definitive fixation, that you've got to work around an incision that's in the wrong place. Again, I can't really generalize because there will be some circumstances in which you really do have to act if it's open and there's a lot of contamination or so on. I think if it's closed, even if it is very swollen, you can almost always leave it until the next day. And by that time, hopefully your foot and ankle specialist is around to come and give you a hand.
Next question, harking back to your own sporting heritage. Does fusion affect athletes? If you're at a pugilist rank, does it affect an athlete's performance, I guess?
I think if you're talking about elite athletes, then an injury like this, whatever you do, you've got to counsel people that this is potentially a career-threatening injury. It doesn't have to be, but there is a significant risk whatever you do. Does a fusion affect athletes? Well, I suppose it depends which joint, because if you have to fuse someone's tarsometatarsal joint, the effect on them is likely to be minimal, even for an elite athlete. But if you've got to fuse, say, the talonavicular joint or the navicular cuneiform joint, or the fourth or fifth tarsometatarsal joints, which you really don't want to have to fuse, that's going to be much more restrictive. I mean, this is outside the realms of this talk, but when I'm talking to people about first metatarsophalangeal fusions, I often show a picture of Leighton Hewitt, who had his first metatarsophalangeal joint fused mid-career and got back to playing at Wimbledon. So athletes can function at a very high level with a fusion, but you want to try and avoid it if possible. But like with everyone else, you've got to think what's least bad. If I'm going to desperately try to avoid fusing them, but leave them with severe pain because I haven't fused a joint that I know is going to be arthritic and cause them problems, I'm better off fusing them, giving them better chance.
In terms of fusions, you mentioned fusing comminuted fractures, so maybe the base of second and third were comminuted. Would you add bone graft in? And if you do add graft in, where do you get it from?
So that's a good question. So I don't fuse the isolated ligamentous ones, I bridge plate them, but I suppose if I was doing, I wouldn't need to use bone graft because there isn't any bone loss. If I'm dealing with a heavily comminuted intra-articular one, again, it depends, because if it's partial articular, you've probably still got enough length. There's enough mush there from the comminution, and there's enough length that you're not significantly chasing that. But if it's complete articular and the whole of the base of the metatarsal is comminuted, then by the time you've taken out the articular cartilage and the sort of croutons that are there, you're looking at a big gap. And you look at that and you think this isn't going to unite, because it probably isn't. Certainly when I'm doing primary tarsometatarsal fusions outside the trauma setting, so down the line for arthritis, there's almost always a gap which I want to fill. And what do I use to fill it? In the delayed setting for my elective patients, I'll usually take it from the calcaneal tuberosity. I don't do that so much in trauma. I'd probably take it from the proximal tibia if I was going to, so that I'm away from the site of injury. I don't like using iliac crest graft if I don't have to.
And do you ever use any artificial bone substitutes? Any DBX, calcium phosphate, sulfates, hydroxyapatite?
I do, but not in this location. I think in this location, if I'm using bone to fill, if I'm using something to fill a void, then calcium phosphate just doesn't quite cut it. I would potentially use allograft bone, but I don't have ready access to that in trauma because it's not kept in my hospital. I have to order it across from somewhere else, which, okay, you've sometimes got time to plan that. In the elective setting, I would be less hesitant about using a femoral head because I can easily get hold of it on a more planned basis.
Yeah, cool, thank you. What's your approach to a non-compliant patient who won't comply with non-weight bearing post-operatively? Old chestnut.
Nothing heals like cold steel. Of course, sometimes you don't know who's not going to comply anyway, do you? You do need your fixation to be rigid enough. And I think on one level, you have to assume that even your more compliant patient may accidentally forget from time to time and put their foot down. So your fixation does need to be resilient enough to withstand that a little bit. Would I operate? Well, yes is the answer to that, and I'd accept that there's a higher risk. If it's dislocated and they need an operation, they still need an operation. And at the lower energy end of the spectrum, if it's only slightly subluxed and you fixed it, then if they go and walk on it, it's probably not going to matter anyway. And at the higher energy end of the spectrum, if they've got some of those horrible injuries I've shown earlier, we've got to operate. You can't just leave them like that. So you've got to operate and just bear the consequences. And I say I non-weight bear them for 6 weeks. It maybe doesn't make quite such a difference as we all think in these patients. But would I operate? Yes, almost certainly I would, because I probably still need to for all the same reasons.
Yeah, and I'm in full agreement. I think you've just got to bite the bullet and you've got to do it. In a majority of people, they are compliant. In the ones that aren't, sometimes you can predict it, sometimes you can't. The ones who are notorious, in my practice are the sort of diabetic neuropaths who have sustained a Lisfranc injury rather than a Charcot process. They've fallen off something and injured it. And I'd fuse those, and like you said, I just fill them full of cold steel, big plates, big bolts and beams if we've got them available. And I stick a cast on for a long time and expect them to weight bear on it and keep my fingers crossed, really. But no, with the same, I think you are almost obliged to fix these irrespective of what the patient's trying to do to your handiwork.
I mean, I haven't really talked about the diabetic foot ones because they'll come up later in the lecture series, and they require a somewhat different approach. They need more aggressive fixation. If you're going to fix them at all, they need more aggressive fixation, as you say. They need a longer period of protection in cast, and double the time for everything.
Good, thank you. Question on the Coatsy paper now. A sort of technical question that I don't understand, but bearing in mind there were sample size issues with the paper, would you consider fusing a purely ligamentous Lisfranc injury in your clinical practice?
Well, it was a very good paper. Methodologically, it was pretty sound, and it was only 20 patients in each arm, but it was big enough to find the effect that they were looking for. Would I consider fusing a purely ligamentous injury? Well, again, and I discussed this with Chris Coatsy a few years back. I think if you were redoing that study now, you would probably compare bridge plating with primary fusion rather than transarticular screws with primary fusion. So what that paper tells me is don't use transarticular screws, and I don't use transarticular screws. I wouldn't fuse a purely ligamentous Lisfranc injury because I think they do very well with bridge plating.
Yeah, and I'm in a very similar boat, really. I think you can always fuse them later. If your fixation has failed or the patient's not happy with fixation, you can always go back and fuse them later. And why remove a healthy joint if you expect it's going to do well afterwards? Speaking of which, timing of your bridge plate removal. If you are going to take them out, and our practice is very similar to yours, I used to take them all out, but it's a horrible operation. There's often a lot of scar tissue in there, and often they don't thank you for it. You're at high risk, fairly high risk of complications in terms of wound problems, scarring, and even nerve injury. It's often hard to find the nerve when you go back in. So if you are going to take, so we don't take much out anymore. We often have that dialogue with the patients, and if the patients are happy, we leave it be. But if you were going to take it out, what sort of time would you consider, or what's the minimum time period for removal?
And I think you've made a good point there before I answer your question. They're not always happy with removing it, and if they're happy, they'll choose not to have it removed because they're getting on with their life again. And if they're not happy, you do need to think very carefully, why are they not happy? Is it just because the metalwork's still in? Because that probably isn't the reason they're unhappy. Is there a malreduction? Are they developing osteoarthritis? Is there a neuropathic component to their pain or something else? Any of which would lead you down a different path. But to answer your question, if I am purely removing the metalwork because that's what the patient has agreed that they want, I wouldn't do it before 3 months. And I would usually, and here we are in the NHS world, the real world, at 3 months, I would be talking to them about removing it. And if they wanted to have it done, I would really want to wait until the swelling has come, not all the way down, but until it's really well on the way to resolving, which will be at least 3 months anyway. By the time they then get to the front of a waiting list, having been listed at 3 months, even before the pandemic, that in my neck of the woods would be anywhere between 6 and 9 months after being put on the list. Yeah. So in an ideal world, if they were having the plate taken out, it might be at 4 or 5 months, but in the real world, it will end up being 9 months or a year.
Yeah, and I think that mirrors our practice very much in the fact that I guess 6 months would be minimum. We try and push it along a bit further than that, but like you said, we'd see them in clinic at 3 months. If they want the metal out, by the time they're on the waiting list, it will be at least 6 months before it's come out. And one final question, if that's all right, Robert, quite an interesting and topical question. How has the COVID pandemic affected the incidence of Lisfranc injuries in your practice? Are they still common?
They're definitely still common. My colleague in my hospital fixed one this afternoon. And I've done quite a few since the outbreak of the pandemic. That's of course only an anecdotal level answer. I don't know whether that reflects practice across the UK. I showed dancing at a wedding, which ain't happening much at the moment. But I think most of the other mechanisms of injury will be happening in the same rate, and I don't see any reduction.
No, similarly, again, is compatible with what we see in Sheffield. We've got a lot of famous climbing areas in Derbyshire around us, and people are sneaking out all throughout lockdown and falling off things at exactly the same rate as they used to. And also, a lot of other people are now flooding into the area, and whereas previously may have gone to Benidorm and sipped some cocktails, are now coming around here locally and falling off rocks and injuring themselves. So it's keeping us nice and busy and keeping us off the COVID wards. So there's certainly been no decline. So thanks very much. I'm going to wrap it up there if that's okay. Thanks for a fantastic talk, Robert. It was truly great, and thanks for answering the questions so succinctly. Can I just remind everyone that this is now the 8th lecture in this series, and so certificates will go out to those people who've filled in their feedback in the next couple of weeks. And then as the lecture series continues, more certificates will be given after the next 8 lectures. So thank you very much, everyone. Have a good evening. Take care.